Good afternoon, everyone. It's welcome all. This our session will start about keratoconus cutting edge, and we are really pleasure to have Professor Renato Ambrosio. I'm sure he's well known. He's adjunct professor of ophthalmology of Brazil, and he's also president of ISRS. And really, it's a pleasure always to have him with us. And he will be talking about. One second. Sorry,
Advances.
disappeared from my screen. Sorry for that.
Okay, you want me to? Sam, it is shown in the screen itself.
It's advances in diagnostic keratoconus, ectatic disease, cornea tomography, biomechanic, and molecular biology. And really, I'm looking forward for his talk because he's always bring us the top and the most advanced way. And really, it's a pleasure to have him with us today. Renato is yours now. If you want to start.
Thank you. Thank you very much. I'm honored and grateful to be here. Thank you for the very nice introduction. It's a pleasure to participate in the Quassim Ophthalmological International Conference, along with friends like Paulo and Ricardo Vintiguera. So my topic is advances in diagnostics for keratoconus and ectatic diseases. We'll talk about corneal tomography, biomechanics, molecular biology. This is my financial disclosures, of course, including Oculus, but my main point is that the main disclosure I would say I have is related to doing the best for my patients. I also have a master class with over 20 hours of presentations recorded on multimodal imaging for keratoconus and refractive surgery. It's not a coincidence that the number of publications for keratoconus on PubMed increased tremendously, starting this exponential increase in the 80s to 90s. It was related to the evolution of refractive surgery. We broke paradigms, eventually create paradoxes, because one of the situations that refractive surgery can aggravate ectasia, the iatrogenic keratoectasia after LASIK, described by Theo Seiler in 1998 for the first time, actually relatively late if we consider the early keratomas used by Professor Burato and Professor Palikaris in the early 90s. But the first cases were related to LASIK and high myopia, in which the impactful procedure caused ectasia to occur. A few months later, still in 1998, we published Pomfrus keratoconus, defined from the front surface curvature with inferior steepening as a cause of iatrogenic ectasia. Those two reports allude perfectly to the pathophysiology of ectasia, which is about mechanical decompensation of the cornea related to the resistance, the innate biomechanical properties, and any cornea may undergo the cycle of decompensation described by Cynthia Roberts and B.J. Dupes, with thinning and protrusion, and of course the impact from the environment. Laser vision correction do weaken the cornea, but the major force against the cornea for any cornea developed ectasia is the eye rubbing. So if you want to avoid ectasia, start by telling patients not to rub the eye, because eye rubbing aggravates keratoconus and even can cause ectasia. This is a major concept on the Violet June campaign, which I invite all of you to participate. And a major message also that I think any cornea surgeon should consider is that aggravating keratoconus is different than causing ectasia. So if the patient sleep over the eye for many, many years, considering the pre-trauma, the innate biomechanical susceptibility, causing ectasia is different than aggravating keratoconus. That's the major point here on the conjecture from my friend Damian Gatinel that agrees. Actually, he says that no rub, no cone. And I highly agree with him, but I would say that some cases with very susceptible corneas may lead to ectasia development, to aggravating keratoconus with minor trauma. And this is important to understand. And this understanding of susceptibility is also related to ectasia after laser vision correction. There's been an interest of concern for major work, for like colleagues like Dr. Brad Randleman, the editor-in-chief of the JRS, has very important contributions in the ectasia risk score system that starts with topography, includes residual stromal bed, pre-op tachymetry, and manifest refraction. But I would say that a very important finding is that age is important. Age is not specific because you can have a young patient with a strong cornea and you can have an older than 30 patient with a relatively weak cornea, as we can see with biomechanical analysis. But another factor here is that abnormal topography should not be considered form-fluid keratoconus. What is form-fluid keratoconus? I would say is frustrating to try to define because there's no consensus. Yaro Rabinovitz, who had great contributions for the understanding of corneal topography, would say that a form-fluid is a patient with an abnormal topography, but normal slit lamp and normal distance correct vision. A brilliant editorial from 2009 on British Journal from Steve Kleiss would say that cases with normal topography from asymmetric or eventually called unilateral, which I would say we have to be careful about this nomenclature, will be the form-fluid keratoconus. I would call those cases very asymmetric ectasia, because without understanding beyond the surface, we cannot say that it's unilateral or fused, but eventually is a continuum from a normality to the disease. So there is no consensus. I really like the concept from Amsler from 50 years ago that he started understanding the abortive, incomplete form of the disease that can progress or not to the full-blown disease for the form plane. My humble contribution is that keratoconus fruste is a patient with a high susceptibility for ectasia progression. Patients like this one that had a little yellow here, this is the IS, the absolute scale from Steve Kleiss, Mike Smolik, and this scale with this little yellow here would say some people, especially if they say the post-op ectasia, that the patient has a pathognomonic for form-fluid keratoconus. But this patient, in fact, had subabdominal keratomiliosis with the residual stromal bed 304, PTA that was less than 0.4, and the patient developed ectasia. And this patient was case number 6 in a publication that we had that demonstrated the subjective variability that is huge among experts. And the mode was 0. The mode on the classification from 9 experts out of 11 would say that this is not abnormal, even using a second scale with a half diopter, which is in the pentacam is called the holiday scale. On the Bellin-Ambrosio was possibly calculated. This patient had surgery before we developed the display, but from the U12 files, the raw data we can calculate. So I would say this patient had ectasia susceptibility with a D that was higher than 1.5 and an artmax lower than 400. It's an anecdotal case. We need to go in population studies, and it took us about 10 years to get 105 cases with ectasia that had a pentacam pre-op. We had expanded that to about 150 cases, and the plots are very similar to this one. We have 3,278 stable cases, and if you see the IS value, the classic Aaron Rabinovitz, here's the absolute value. It doesn't matter if it's inferior steepening or superior steepening. It's very specific, 98% specificity, but the sensitivity will be 22.9. So it's important that we go beyond the surface, and the BAD-D, which was not available for most of these cases, we detect 59% of cases with a 1.5 cutoff value. Can we do better? Absolutely, yes. The Brazilian Artificial Intelligence Network, the Pentacam Random Forest, nicely developed in the thesis of Bernardo Lopes. We have an enhancing of sensitivity and specificity. Looking at both eyes, I would say this can increase the sensitivity up to 85%, but we still have cases down here, which needs more data, more analysis. And segmental tomography can be done with high-frequency ultrasound. Very nice work by Professor Reinstein in the 90s that he started looking at digital ultrasound and capability for looking at the epithelial thickness and this thinning of the epithelium that would be coincident to the area of steepening will be an ability of the epithelium to try to get a thinner zone here to minimize the protrusion of the stroma. So this is done by ultrasound, but was definitely popularized by the work using OCT, Fourier domain OCT. Professor David Kwang in his lab, the cool lab, with very good collaborators like Yan Lee, they were able to segment the epithelium with a very high repeatability. They also developed the pattern standard deviation for the cornea, pachymetry and epithelial pachymetry maps. and unfortunately it was not available. We have cases like this one, and I started using the ArchiView in 2013, so it's about 10 years of experience, and I have the ability to see when is a steepened cornea. You see from the placido here, you see from the shine fluid, the steepening of the curvature maps, and this patient has obvious epithelial basement membrane dystrophy, Coogan's dystrophy, and eventually you may claim that this patient has mild keratoconus associated, but I would say this is the patient that would definitely benefit from surface ablation. So enhancing specificity is very important. It's important that we see that there's a revolution on machines. We have many machines that we have been experiencing great results on corneal OCTs. It's an OCT revolution, as I say, the MS39, the Anterion, the CASI2. We have some multimodal imaging systems that, for example, the Rivo that can do axial length, can examine the back of the eye and the cornea. We have the Sirius from Zeiss as well. The Anterion is a very good biometer. So we have a huge plethora of exams. Every year, I would say, in a meeting, I see a new OCT that can measure the cornea. So it's a very important thing that we see that it's not only OCT, the shine fluid can do epithelial thickness, the procedure from Italy can do epithelial thickness mapping with the shine fluid imaging, and the Pentacam, I can tell you today that we will have a higher resolution shine fluid and an OCT, spectral domain OCT, for improving epithelial thickness. Epithelial thickness is not the only thing that we can do. We can have the elevation and curvature from the front surface of the stroma. If you haven't removed Bowman's with a PRK, for example, you can have like a Bowman map, and that will be a very important factor for therapeutic procedures, for therapeutic ablations. This is a very nice work led by Raj Shetty from Bangalore, India, with colleagues like Abhijit Shincha-Roy. This is very interesting and very promising, in which you can see the curvature and elevation from the stromal surface. Julie Schallhorn and others, they demonstrated that a thick epithelium can be related to a warpage, and a thin epithelium is related to keratoconus. This is actually the basis for the law of Reinstein for epithelial healing. The epithelium has an ability to alter its thickness. So it's a very important concept that we understand that the epithelium is a secondary modulated change on the cornea. It's not the primary change on the cornea when we have ectasia, but it's a secondary and very important for our vision. Irregular astigmatism can be masked by irregular epithelium. And I would say when you have our higher order aberrations, when the epithelium has reached the maximum level of modulation to try to modulate and smooth the surface. Nice study by 2017 that we reviewed the epithelial role for refractive surgery. This is a fellow eye of the patient with a mild keratoconus, and you can see epithelial thinning here. If you see mild to moderate and advanced keratoconus, you see the thinning of the epithelium related to the elevation maps and the curvature maps. In a very advanced keratoconus, you have some thickening of the epithelium as well, which relates to the area that you had severe loss of tissue. After Kera rings, after corneal rings, you can have a modulation of the epithelium. This patient is followed by Professor Reinstein in London. You see the thickening of the epithelium, the thinning of the epithelium, and this patient has a fellow eye that was very interesting. Everything normal on the front surface, normal distance uncorrected vision, and we consider this patient electric ectasia. This patient had a great result with the corneal ring, as I've shown you, but the patient had all the exams normal in the left eye. And normal, and not only normal on the surface, normal on the epithelium, normal on SCORE, which is their OrbScan-based artificial intelligence developed by Damian Gattinel. And also, we had a TBI. The TBI was able to detect 0, and this is a retrospective calculation from 2014. So we developed that algorithm in 2016, the first version, and then we can back calculate that. This patient came back for a second evaluation, 2018, and he was very stable. When we think about biomechanics, we have to consider what we have today. And today, in my suggestion, my opinion, I would say that the Corvis taking 31 milliseconds images, 140 frames, we can definitely understand a lot of information from the deformation, the velocity. This is a very nice work that I was very honored to collaborate with Paulo and Ricardo Vinciguerra. Ricardo got the Troutman Award in 2017 for this work, so that we can see that the cornea, if the cornea is stronger or not. So this is very important. I have to restart this. Sorry for that. So when we integrate corneal tomography and biomechanics, we have the TBI. This is artificial intelligence in practice, and with a cutoff of 0.29, we had a very nice sensitivity and specificity to detect cases with a normal topography that had the keratoconus or ectasia in the fellow eye. So this is a continuum of understanding of susceptibility, and I would say that this is the basis for my understanding of ectasia risk assessment. So that the patient has a phakic IOL, it's not only ICL, we have the ICRIL as well, but we should understand also the relational tissue that we alter when we do surface ablation, LASIK, or SMILE. Or if the patient has only the ability to do a ICL or a phakic IOL or ICRIL phakic, or if the patient has a therapeutic procedure. So that's how I use this data for customizing. And it's not only efficiency, but also sensitivity for detecting abnormalities that would preclude complications. So safety is very important for us. So we have cases like this one, 2015, with a mild correction. Everything would look even normal on tomography. But if you see, there is a TBI of 0.41. And this patient had a fellow eye with a mild keratoconus. So we enhance the sensitivity and detect in this normal topography eye some susceptibility. Shizuka Ko from Japan, she published 3 daughters of a patient that had keratoconus, and she had evidence of susceptibility. And all the 3 daughters had a normal slit lamp and this correct vision better than 20/20. And these patients had many abnormalities detected on the level of biomechanics and tomography. So it's important that we understand that we can have form proofs in both eyes. This is the identical twin sisters. First was asymmetric keratoconus. The TBI was 0.58. The TBI in the 2 eyes of the other sister, identical twin sister, actually it was confirmed by genetic analysis that they were twins, and also that they had some moderate risk for keratoconus, not only on some genes related to the stroma, to the substantia propria of the extracellular matrix of the cornea, like the collagen, but also related to inflammation. It's very important that we understand that. So genetic tests had a potential for a real new revolution in diagnosis. Genetic tests will be very important for us to go beyond the imaging to increase sensitivity and specificity for ectasia risk assessment. Nice work by Professor Shetty. Again, he has done brilliant work with molecular biology. So lysyl oxidase will be deregulated in collagen levels. And he has demonstrated in a patient that had SMILE-related ectasia, and this patient had the lenticle frozen, and he was able to retrieve the lenticle and compare the lysyl oxidase and see important differences on the levels of lysyl oxidase on the levels of the stable SMILE cases. So it's a very promising data. Other molecular factors that can be applied is related to MMP9, IL-6, and this is something that we definitely would have in our practices soon. I just want to finish with a very important case presentation. There's a young lady, 6 years old, that came in December 17 for the first time. A colleague of mine, very good cornea surgeon, would say that she needed a transplant in the left eye, adult, and a cross-linking in the right eye. She had 20/25 distance correct vision, 20/30 uncorrected in the right eye, and he wanted to do a cross-linking because of what happened in the left eye. She rubbed the eye tremendously. She is 6 years old and has 2200 with a very big anisometropia, and that's a huge risk for amblyopia. But the right eye first, we should understand the thinning of the epithelium, the abnormal D, The abnormal TBI, TBI-V2 that we can now calculate is very abnormal. So the patient has unquestionable mild ectasia, fluid ectasia, whatever you want to call, but should she need surgery in the right eye? That's a question. You have to consider risk, benefit for that. However, the fellow eye should have done surgery before because of the risk of amblyopia. So it's a paradox, because here I would say she doesn't need, but she needs to follow. Here she should do as soon as possible. Importantly, she was able to understand the patient, and the family has to understand. She's a young lady, 6 years old, but the family has to understand it properly. No eye rubbing, and surgery for the left eye would be a stage surgery along with occlusion therapy for treating amblyopia. So I had a colleague of mine, Dr. Thais Silveira, did very nice work to help me managing this patient. So importantly, this patient had to understand the no eye rubbing. We first did a corneal ring implantation with a femtosecond laser, and I used the ring channel for riboflavin injection, and I do epi-on cross-linking. She did relatively well, and she got 20/80 she was able to tolerate nicely the occlusion. About between 6 months and 8 months, she started having problems, and we decided to do more surgery, and we did a modified Athens protocol. Today we call this the Tel Aviv protocol. We do the epithelial topography guided ablation, and this epithelial ablation was followed by PTK smoothing, and then we did a fast cross-linking. The patient did very well. I think we were really lucky, and actually more than lucky, may say, and she's still stable up to this year. Actually, she's coming, I think, next week for the next visit. And she's 2015 distance correcting the right eye today with no surgery. She's taking oral riboflavin, which I believe is very important for her. And 2025, we definitely did go and treat we were successful treating the amblyopia. And this is the last examination. You see the topometric from the shine fluke, and also the very nice evolution on the OCT. You see the epithelial regularized after the ring and after the modified Athens protocol. This is 2022. So the patient is stable on the right eye. She's stable based on topometric from the shine fluke, from tomography, the ABCD from Michael Bellin. The tomography and biomechanics is the E, ABCDE, with the Corvus. Nice work by colleagues from Humboldt, Professor Seitz. And this is also a very interesting situation that she didn't need surgery. So advances on the Watts, screening for ectasia risk, is different than when we manage patients with keratoconus and ectasia prior to keratoplasty. This is a huge breakthrough for a paradigm shift, but we create paradoxes, and we have to understand the questions. And the major message is the artificial intelligence applied, along with the wise, the ancient intelligence, which is philosophy, understanding screening, diagnosing, staging, prognosing, classifying. Clinical follow-up is very important. And there's a true revolution and evolution that we have with multimodal corneal imaging. So thank you very much for your kind attention, and look forward to having good discussions and learning from all of you. Thank you.
Thank you very much. That's a very good comprehensive talk. Great to learn from you as usual. One question regarding, as you know, nowadays, corneal epithelial mapping and biomechanical force, especially referred to laser procedure. If you had the budget, which one you go for more important, epithelial mapping or biomechanical? I know it's better to have both for screening for laser correction.
Well, your question is great, but imagine if you are jumping on a plane for 12 hours coming to Brazil, and the pilot asks you, what's the budget? You ask the pilot, what's the budget that you should get? You get the engine fixed, or you get your bussola or the compass fixed? It's hard to say what is the most important one. I can tell you what I have more experience with. I would say the challenge that we have as clinicians is that we have to manage our practice, the private practice, and we have to optimize cost benefit. And for example, this year I'm doing a very nice course, which is the Physician CEO in Kellogg. It's a very nice comprehensive training that we should have had during medical school for understanding what is important in terms of business decisions. So there are two big questions. One is a business decision. The second is a scientific decision. On the level of the patient safety, I like the wisdom from the art of war. You have to understand yourself and you have to understand your enemy so that you can win the battles. What is the enemy? The enemy is the problems that we can have. So it's enhancing safety and enhancing the ability to do the best work as possible for efficiency. So when you ask me what I have more experience, I've been working with the core of the since its development. So I have a huge bias on my knowledge because I started working with that in the very early phase. So this is what I use most. I have used, when I saw the RTView doing repeatability acceptable maps, I said, I need to invest on that. And I invested. Uh, it was not easy. I have a small clinic, relatively small clinic. So to start with the RTView 10 years ago was an investment that was not easy. But I took it because I was really conscious that I needed to have that information for example, for planning for surface ablation, for epithelial ablation with the PTK that I'm doing since 2008. And I needed to have the epithelial data for looking at therapeutic cases, even though we don't have a link with the laser. This is something that helps me a lot. So you have to understand what is the best for your practice. That's a decision, and what is best for your patients. So I would say colleagues, ophthalmologists should work together. It's no sense to have everything in different places very close because we can optimize. So, but it's a challenge. It's a challenge. But in terms of budget, I think I did give you my rationale. But if you think about a continuum, what happens first? Epithelial change or biomechanical change? What do you think it happens first? I give you this question.
It's
Do you think that epithelial
it
changes
should be
before
biomechanical
biomechanical?
change. Should be biomechanical change, but is and technically, if it's a weaker cornea, biomechanical first, then the epithelial will be the second.
That's exactly how I think. So, but AI is able to identify what's going on, and today we have very good AI for epithelium, for corneal biomechanics and tomography with Scheinfeld. This has matured. We have thousands of patients analyzed, and it gets better and better. With the epithelium, it's coming. It's definitely coming, but we need to be able to ask the right questions and develop the proper tools for the artificial intelligence. So, long story short, I would not throw my epithelial thickness. Today, I use 5 epithelial thickness mapping devices, 5. And I only have 1 Pentacam and 1 Corvus. And also have 4 devices for polyobarometry, which is something that probably is not so important. But with this plethora of data overwhelms you. So you need to be effective on what you're looking for.
About BOMS, is there any machine now available taking epithelial mapping in consideration with topo-guided treatment for regardless the keratoconus or any, just to take the epithelial mapping, take it out like BOMS mapping, and you apply with eczema laser? Any machine available do that?
This is a good question. Today, we don't have anything ready as I wish. My wish is to have a link between the OCT and the eczema laser. So we have epithelial-based tomography to calculate. But even when you have Scheinfeld tomography, we have, for example, the Oculizer, which is the Pentacam connected to Wavelight. We have the Sirius for the Schwind laser. Both of these tools, they are not giving tomography, they're just giving front surface elevation. So it's still something that we have to develop, and the link between tomography and eczema laser is there. But one consideration is that when you do an ablation for keratoconus, you're not thinking about refractive.
Yeah.
You are thinking about therapeutic. It's very important to understand. But I would do topo-guided, front surface topo-guided, with a conscious understanding of the epithelium. And the good thing about it is that the PTK, a flat ablation, can help you because the epithelium is giving the mass that you need.
Yeah, thank you very much. That's a really great talk, and thank you to have us with us. The next talk, which will be, I think, recorded with.
Can I have one question to Dr. Renato?
Oh, please.
Yeah, if you had any question from the.
Yeah, I want to highlight a little bit about in diagnosis of suspicious keratoconus. Yani the way how you are going to deal with suspicious keratoconus cases?
Well, uh,
I know it's a very big word, things,
yeah, it's a
but just a certain point, because it's still, a big problems for most of the.
Dr. Amari, it's a very important question because I have this question every day to myself. But I think we have to consider the nomenclature. Steve Kleiss was very keen on developing the first artificial intelligence methods for topography evaluation to detect keratoconus, and he had a label of keratoconus suspect. I would say that the suspect for me is everybody. I don't need to do any test to say you are suspect. So I want to do the test to understand if the patient can have or not the surgery, if the patient may need a procedure in terms of therapeutics. So when I think about how I approach this question is how I approach every case with multimodal imaging. So everyone is a suspect and everyone should have a complete examination so that I can get the data analyzed for proper medical decision. And safety and efficiency are on the top of the list for the reasons for doing this plethora of exams, and we have to be keen. I would say topography of placebo is still important because of the surface epithelial tear film analysis. Tomography with the shine field along with biomechanics with the corvus is going to be important because of the maturity that we have in terms of AI. And OCT is very, very important as well. So I look at this data and I try to make a cautious decision for every single case. It's even though I use a lot of AI, I also sometimes ignore some of the data that I have on AI based on the meaning that we have. And some cases are really out of the curve. And eventually those are the cases that are referred to me. And you see that you can learn a little bit every day, a little bit more.
Thank you.
Thank you
Different
for
question really for that. I'll ask about something about the BRK extra or LASIK extra. Do you do that, and what you thought about it?
I just showed you an Athens modified Athens protocol that I have done with a very nice lady that is growing beautifully. But again, it goes to the point of what is therapeutic and what is elective. I really don't think we need to go for extra for like a peace of mind or opening the door for doing more cases in for refractive elective procedures. I remember when Theo Seiler came to Brazil and I gave him the Barraqui Award in the Brazilian cataract and refractive meeting, Braskers. It was 2014. And he said, we need to do a study that is going to be very complicated. It's going to be a very long study with a large number of patients to demonstrate that LASIK extra is better to reduce the risk of ectasia. And I said, okay, you need maybe 3,000 cases in each arm, LASIK and LASIK extra, and follow this patient between 3 and 10 years because that's when ectasia occurs. Interestingly, I said, we just need one case of ectasia after LASIK extra to demonstrate that LASIK extra is not bulletproof. And he said, it will never occur. It happened to have in the literature, JRS, Sunil Sufi, he published an interesting case with a very low risk factors. The patient had a keratome LASIK and had with LASIK, actually had LASIK extra because of being young. And this patient had LASIK extra later ectasia. So I don't believe in the extra concept. If you see on the biological of cross-linking, I'm not the most knowledgeable person on this. The very little cross-linking that would even occur is not sufficient if you do the number of seconds that you have a cross-linking effect. So I don't believe in that.
Me too. I've never done it really, but just some people do it, and I think there nowadays is any caution, any suspected case, you have to do epithelial mapping. You do corpus. You have to go all the way before touch this patient.
Eventually, not touch the cornea, go for a fake IOL.
Yeah.
Eventually, consider follow-up. You know, when I was doing my fellowship with Steve Wilson, he said, for many cases, you have a suspicious cornea, and this was based on topography of the placido and central corneal thickness with the ultrasound. He would say to the patient, come back in a year. If you are stable, we can go ahead and do PRK, but I think you may have you may be developing some keratoconus. At that time, we didn't talk about eye rubbing that much, but that's what I do. I treat the cornea with anti-allergic, tears, tell the patient not to rub the eye, riboflavin oral, omega-3, and have the patient come back. And the most important thing that we give is patient advice, patient education, not to rub the eye, understanding what is ectasia, and that's what's the best for this.
Yeah, thank you very much. That's a great
My
talk. And
pleasure.
eye rubbing is a big problem, and really patient should be educated. And the family, all the family, I told us the family, all the family asked them to stop eye rubbing.
Yes, yes. If you have somebody rubbing the eye next to you, it's going to be bad for you. So join the Violet June campaign. Don't rub your eye. Learn about keratoconus.
Thank you very much. Thank you very
Thank
much.
you.
Thank you very much. So next is
Us also we have just
Go ahead,
Renato,
Mom.
if you stay with us for discussion after the second one, if you don't mind.
So next speaker will be Dr. Ricardo Balfensiguera. His father, Dr. Paulo, couldn't join us, but is so Dr. Ricardo is well known for his current work in ophthalmology. He do a lot of work in the biomechanical and corneal related disease, keratoconus, corneal cross-linking, keratoconus, and he will send us the recorded talk. Can you share, Mohammed, his talk from your side?
It will be shared, yeah.
Hello.
So he will talking
This is
about what's
Dr.
new in
Vinciguerra.
corneal cross-linking. You
And
can
it's really
start.
a pleasure to present the talk What's New in Cross-Linking at the 8th Cassini International Conference. This is my financial disclosure, and none of them are relevant for the talk. When I received the title of the presentation, I thought what to speak about what's new in cross-linking. And in reality, what I think is very important when you want to understand new updates in cross-linking are the risk factors and the long-term efficacy of what we already have. So I made a review of the literature, and I wanted to speak with you about what are the risk factors that are known for regression, for progression pre-op and progression post-op. The first important is progression pre-op. In particular is young age, eye rubbing, atopy, Down syndrome, and steeper Kmax. And the progression post-op again is younger age, steeper Kmax, thin corneas, and atopy. The most important study in which evaluated the progression after cross-linking was by Lenk et al. They evaluated 230 eyes with a minimum follow-up of 3 years. And the risk factor for progression of keratoconus after cross-linking was a high preoperative Kmax and the presence of neurodermatitis combined with atopic disease. So the first very important take-home message is that high-risk corneas are in general young patients, advanced patients, and atopic ones. So why I think that this is important for you when we speak about what's new in cross-linking? Because there are a lot of new protocols that are available. There is transepithelial cross-linking, and I'm going to show you some long-term results. There are new protocols, but the first thing we need to remember is that we need to treat our patients with the highest level of safety for them. So if we have very high risk cases, we should stick to what has been published to be the most successful treatment, which is the epithelium of cross-linking. So remember that in high risk cases, my humble suggestion is that you stick to protocols that have been proven to be very safe. So I'm going to speak about long-term outcomes of epithelium of cross-linking and also about iontophoresis. So I can explain you what is the evidence that is available at the moment for long-term studies. Let's start with epithelium of cross-linking. So there are 4 studies so far that evaluated long-term efficacy of cross-linking. The last one that came out is from Ricecup et al. That has 15 years of follow-up. Then you have the Mazzotta with 10 years, which is pediatric, Nikula et al. With 10 years follow-up, and our study with 13 years of follow-up. Let's start with Ricecup, which obviously we know that is the hometown of cross-linking. They showed the results of 42 eyes with at least 15 years of follow-up, and they showed significant flattening with 67% of patients that had visual acuity that was stable or even improved, and retreatment was needed only in 14% of the cases. So you should expect your patients that have cross-linking to have the possibility to be re-cross-linked. This is something that you need to tell to your patients, and that also you need to take care of them and keep following them up. Similar results was coming from Mazzotta. They showed 10 years of follow-up of pediatric patients with a progression rate that was 24%. But we need to remember that these are progressive patients and very aggressive because they are pediatric. So that means that these patients are more likely to progress. Nikula et al. Showed 10 years follow-up with improved visual acuity and keratometry, but they did not report any progression. However, when we speak about definition of progression after cross-linking, it's important there is no consensus regarding what is the definition of progression pre-op. So imagine if there is consensus of the definition of progression post-op. But additionally, if we use a single value like Kmax, it is known to be poorly reproducible, and many authors suggest to use even more than one measurement. So, we use the definition of progression after cross-linking with the ABCD progression display. Why? Because it is not based on the single value, because it's an average value of anterior, posterior curvature and thinnest point. And there are also 80% and 95% confidence interval for normal and keratoconic population, but also there is the possibility to have the 95% confidence interval after cross-linking, so with the noise level of patients that have been already cross-linked. So these are our definition of progression, and I will show you in a second how they worked in the long-term follow-up. So let me show you first the 13 years follow-up after cross-linking with AP-off. So we had 27 eyes of 22 patients with a mean of 11 years of follow-up. All patients were progressive with at least one change of Kmax and or a 20 microns reduction of pachymetry. We showed significant flattening over time and decrease of A value. Based on the progression criteria that I described you before, we had 7.4% patients that required progression or required further surgery. And now this is a big news that I wanted to share with you, particularly because we're speaking about what's new in cross-linking. This is hopefully going to be published very soon, and these are our outcome of cross-linking AP-off with 14 years of follow-up with pediatric patients. We included 38 eyes of 24 patients with a minimum of 10 years of follow-up and a maximum of 14 years. And the progression pre-op was defined as before. Main results, we had an improved, significant improved in visual acuity of more than one line. And you can see also that the A parameter was also improving, which means that the patient were getting significantly fatter. Based on the previously described criteria for failure, 34% of the cases progressed. But this is only if we consider also posterior curvature and thickness. If we instead consider a significant change based on anterior curvature that was only a 77.1% of change, which is important because if you have a patient that is progressing only with posterior curvature, you might not want to recross-link the patient, but it's important to know that this patient will probably get worse in posterior curvature before anterior curvature gets worse. So as a second take-home message, standard cross-linking is safe with intermediate progression rate in pediatric and is confirming Mazzotta's finding. So we need to be careful with definition of progression. Last but not least, I want to discuss with you about long-term follow-up of iontophoresis transepithelial cross-linking. This is the only study in literature that has 7 years of follow-up with iontophoresis. This has been published and we showed no significant flattening over time. Conversely, we found a significant change in chromatic aberration, which means that cross-linking transepithelial with iontophoresis is able to reduce coma, but is not able to significantly flatten the cornea. And this is how you can see the change in chromatic aberration over time. So there is a significant change from 0 to 12 months, and then pretty much is the same up to 7 years. Based on the previous described criteria, 4 cases had a significant progression, particularly after 1, 6, and 6 years of follow-up. Remember that here we are also considering a change in posterior curvature. So, as a main outcome, we showed that iontophoresis cross-linking is able to stop keratoconus progression with an intermediate progression rate. So, based on long-term follow-up, we can say that pretty much a patient that is non-pediatric and has been treated with iontophoresis is as much likely to progress as a pediatric patient with epi-off cross-linking. So, as a discussion, it is important to note that if we base our definition on the event of recross-linking or transplant, only 1 patient would have progressed in this iontophoresis cross-linking study. Instead, if we would have used a change in Kmax, only 2 patients would have progressed. With the above criteria, instead, 21% progression rate was evaluated. So in conclusion, long-term outcomes of iontophoresis cross-linking show that it's a safe procedure, but it might suggest not to use iontophoresis transepithelial standard cross-linking in aggressive patients, unless we consider to use new standard, new iontophoresis cross-linking, for example, the one that is using increased and total ONRG's dose or pulsed UVA cross-linking. This is, for example, another study that we did in collaboration with Professor Mazzotta, in which we showed very good results. And with this last slide, I thank you very much for your attention.
Thank you very much. That's a great talk. It's I think I'm not sure if you're able to join us. Dr. Mohammed is able to join us, so I cannot hear you, Mohammed.
He is not able to join. Sorry, Sama. He will not be able.
A question to Professor Renato about this epithelium on and off. Do you do epithelium on or?
Yes. We have developed a technique with scleral lens. We use riboflavin in the scleral lens, and we put the scleral lens for 1 hour now. And this protocol can allow the riboflavin to penetrate very nicely on the stroma. We have the first 35 patients that we are having 1 year follow-up with very good results. The recent Braskers, about a month ago, my fellow is doing a PhD thesis on this. He got a very nice award of this technique. So I believe that epithelium on is a must. There are different ways of doing that. We have the Michael Bellin is the chief medical officer of a very interesting approach for epi-on as well. They have an enhancer for allowing the riboflavin to get into the cornea. And I would say that having an enhancer in this approach for the scleral lens as a reservoir for keeping the riboflavin on the surface for about 1 hour will be the best strategy for that. in terms of indicating cross-linking for that lady, for example, if I had that technique, I would definitely go for that. But today, the question is, with what we learned from riboflavin oral, I would say we should prescribe oral riboflavin to every kid that has suspicions of keratoconus, and tell them not to rub the eye and tell them to play in the sun.
And this is clear lens. Do you soak it again halfway, or you keep it? It should be enough and top up with just.
We put the riboflavin, we do topical anesthesia, and before the patient gets in, we just put the instead of having the serum, the regular physiologic serum for the contact lens, for the scleral lens, you put riboflavin. It has
but you don't need to top it more. Means one is enough.
No. One is enough. It's a lot of riboflavin that sucks in the cornea. And once you do that, you leave the patient at the waiting. And eventually, one of the patients here have some leakage, and we have seen a couple cases that happen. But when you master the technique, it's very straightforward. So you don't need to. You just do it once, and the patient comes in with the contact lens. We take the contact lens out, and we do a lot of tests. We do OCT, we do pentacam for looking at what's going on. But we have a lot of noise in terms of. It's hard to see objectively that riboflavin inside the cornea. But I think that epi-on cross-linking would definitely indicate. When we first saw the idea of doing cross-linking, it was they tried to use it as a concept of a vaccine. A vaccine. If you have susceptibility for the disease, you need to have it. So, and using cross-linking epi-off in a large population, I would say is much more risk than benefit. Tobias Kohler, he published a very nice study about 15 years ago that if the patient has 20/30 or better distance-corrected vision, the chances for losing vision is very high. So it's kind of an obvious thing, but if you have a good vision, you have to be careful in doing epi-off crossing. But if you need, you should do it. And the question is exactly what Ricardo said. We don't have a very clear line what is progression or not. That's why you have to be objective. And I do look at the A, B, C, D, and E now with the pentacam and the Corvus for progression. And eventually, if the patient needs, the paradox is that he should do as soon as possible. But if the patient is 20/25 or 20/30 or better and is stable, I think the patient does not need and should not, because the risk of a problem doesn't make the point. But epi-on may change this view. Epi-on definitely may change this view. And iontophoresis was very, very nicely. It was a big boom. I didn't have an opportunity to work with it, but I was very close to investing on this type of technology, even though it was not approved in Brazil. But I was not so confident with the benefits. So because of the epithelial trauma, etc. But I think it's, Ricardo and Paolo, they are one of the most experienced in cross-linking in the world.
And about oxygen, do you use any oxygen supplement or Raptelimon or not?
I like the idea of the boost, but as the biochemistry of cross-linking, we know we need oxygen, and maybe it will be a second necessary thing to improve the efficiency. So, but how to do it is still a question. There is a mask that Avedro developed for that, and this mask is very simple. It's not so complicated to mimic, but I have some other ideas that eventually we'll be using soon. And pretty much is to have a flow of oxygen with a scuba dive mask that can be designed for that, and that's something we can do. But I currently don't use it.
And what's your setting usually for standard cross-linking, energy-wise and pulse and duration?
I go for the 9 milliwatts per 10 minutes. Yeah, I've used 18 for 5, but I think it's too fast and too less cross-link. But today I talked to Hafezi a couple of times and Emilio Torres. They are increasing the dose, not only 5.4 joules per centimeter square. They are going to higher dose. So the endothelium toxicity, which was a concern in the past, is less of a concern today. So you can increase the dose and eventually with the boost go with a little faster. One thing I don't do, and I really don't do anymore, is the 3 milliwatts, 30 minutes. I really don't think it's a rationale for that. Actually, if you have a philosophical question, what is the difference between poison and medicine? It starts with the dose. We have other differences, but the dose, and of course the dose of 3 milliwatts per 30 minutes is much higher, the amount of cross-link that you induce, but eventually I don't think it's necessary for, maybe for some pediatric cases you may have a claim for that.
Yeah, it's thank you very much. That's a great discussion from your side, and really, it's a pleasure to have you. Any question from the audience? Please, you can put in the queue box. We had 2 minutes to go. So very crucial, this as you discussed earlier about this continuous follow. If you do keratoconus, do cross-link, it's very important to explain to the patient that you need to follow them, because there's a percentage of them, they need another boosting, especially if they're young age.
All the cases that I saw progression after rings or cross-linking, they are very, very aggressive eye rubbers. They rub the eye. So, and they keep rubbing the eye. That's what we have to consider.
And what do you think about this role of inflammation that some people advocated to, like Christes and other things that can play a role for not to progress people with atopy and other?
I use anti-inflammatory for those patients. I use olopatadine or the Lactacaft as well. I also Trialose. Trialose is a very nice agent that has been introduced with hyaluronic acid as an anti-inflammatory type of effect.
Yeah.
But you have to be careful with steroids for kids, of course, because they learn that it's a good drop and they start using it by themselves, and they may have cataract and glaucoma. And so you have to be very keen. Actually, patient education is the most important thing. And treating inflammation in a custom way, maybe in the molecular biology test that POSCHECK will develop, so that we can see what's the best strategy for treating, if it's a steroid, if it's a cyclosporin, when to use which type of treatment, that will be very beneficial. So customizing, but you need to change the cycle of inflammation and allergy. You need to break that.
Thank you very much. And this is the end of the session. Thank you very much. It's really a pleasure to have you with us.
My pleasure.
I look forward to you in person, so hopefully soon. Thank you, Dr. Mohammed, and thank you for all
Thank you, Dr. Osama. Thank you, Dr. Renato. It was an excellent session. Thank you for being with us, Dr. Renato. Dr. Osama, thanks a lot. Thank you.
Have a good afternoon. Bye-bye.
Thank you. Have a good morning for you all. Again, thank you.